Good afternoon, everybody, and welcome to this afternoon's Focus on CLL webinar. We're delighted today to have two experts in the field of CLL present for us today. We have Dr. Blanca Espinet and Dr. Panagiotis Baliakas. At the end of today's session, we'll also have a Q&A session, so please feel free to submit your questions via the questions box facility, and I'll monitor this during the presentation to ask the questions at the end. So our first presenter today is Dr. Blanca Espinet, and Blanca graduated in both biology and pharmacy at the University of Barcelona and has a PhD in biology also. She's currently the head of molecular cytogenetics and head of transitional research in hematology neoplasms at the Hospital del Mar in Barcelona, and is also an associated professor at the Department of Medicine and Life Sciences at Pompeu Fabra University in Barcelona. So Blanca, over to you.
So thank you very much. First of all, I would like to thank the organizers, Jim QA and Fiona and Katrina, for inviting me to give this talk. And today I will talk on chromosome binding analysis and FISH in CLL. So CLL is the most common leukemia in adults in Western countries, and it appears at a median age of 70. And it is characterized by a proliferation and accumulation of clonal B lymphocytes in the peripheral blood. These cells are small and mature and expressed in a aberrant way CD5. The etiology is still unknown, and the median survival is around 10 years, but it is highly variable. And that's why we need prognostic and predictive biomarkers to establish correctly which patients are going to perform better and which ones need more strictly follow-up. Regarding prognostic biomarkers, there are several types that have been described along the years. And here you have a summary, and I have marked with the arrows those that are genetic biomarkers. You can see here cytogenetic abnormalities, as well as those related with the B-cell receptor and those related to gene mutations. Regarding the prognosis in the clinical way, we follow the CLL International Prognostic Index that was published in 2016. And in this prognostic index, you can see that there are 5 items, and 2 of them are genetic items, genetic biomarkers. One of these is the TP53 status, and the other is the IGHV mutation status. These biomarkers allowed to classify patients regarding their prognosis. And the International Workshop on CLL guidelines that are still valid were published in 2018. And you can see here this table, the additional tests that should be made before initiating any treatment were the molecular cytogenetic aberrations identified by FISH. You can see here deletion 13q, deletion 11q, deletion 17p, and that trisomy 12, as well as mutation of TP53 and IGH mutational status. In this table, you can see also the genetic abnormalities using conventional karyotyping that are not generally indicated in general practice, but desirable in clinical trials. And then you can see here the ESMO guidelines that were published in 2020, and you can see here marked in blue the same biomarkers, and again the complexity chromosome binding analysis, that is something that has possible prognostic and predictive relevance, but it's not yet established. Okay, then which are the biomarkers that we should test? Cytogenetic abnormalities, mainly FISH, but also chromosome binding analysis and genomic arrays are some of these techniques. TP53 mutations and IGHV mutational status. In this presentation, I will talk on cytogenetic abnormalities, and Dr. Baliakas is going to cover the other 2 biomarkers in the next session. Okay, regarding cytogenetic abnormalities, these are defined by the donor hierarchical model. This model was established in the year 2000, so many years ago. And in this study, they tested different genetic aberrations, and they ended up with 5 different subgroups that were exclusive. And they defined 4 different cytogenetic abnormalities that could stratify patients with different prognosis. From that point, the gold standard technique to detect these abnormalities was FISH. So now what we perform is, from a peripheral blood sample from a CLL patient, we test FISH using 13q and 12 and TP53 and ATM FISH probes. Here you can see again the classification taking into account the Downer hierarchical model, and you can see here that the worst prognosis is TP53. Then we have 11q, trisomy 12, that are patients with intermediate risk, and 13q deletions. Patients having these abnormalities normally have good prognosis. Regarding TP53 deletions, these are located in chromosome 17p. You know that TP53 is located in 17p13. These deletions account for 5 to 10% of patients at diagnosis in CLL, and they can rise up to 45% in patients refractory to chemoimmunotherapy and to 65% in Richter syndrome. P53 is a tumor suppressor gene, you know, that is the guardian of the genome, and patients with these deletions and mutations, which are going to be covered by Dr. Baliakas, are associated with a very aggressive disease, genomic instability, and resistance with 2 chemoimmunotherapy treatments. New targeted drugs, such as the ones that have been developed the last 5 to 7 years, such as ibrutinib, acalabrutinib, or venetoclax, act independently of the TP53 pathway and are very effective in these patients. So, summing up the FISH testing and analysis, the samples that we need to test are normally peripheral blood, because this is the sample in which we have the most infiltrating tumor cells. And these samples can be heparin or EBTA, no problem, because we don't need to establish cultures. We fix the cells, and alternatively, we can use bone marrow if it is infiltrated, or lymph nodes in case of small lymphocytic lymphoma. Regarding the probes, we normally test for 13q centromere of chromosome 12, 11q 2223, where ATM gene is located, and 17p. For TP53. The number of cells that we need to score, the minimum number is 100, and the cells should be rounded, not granulocytes. And the cutoff values for each probe should be established by laboratories, and you have to keep in mind that the cutoff should be done independently if you use manual scoring or automated scoring. Regarding reporting, in the report you should define the sample that has been used, the FISH probes and manufacturer, the number of scored cells, the results for each probe. It has to be written text, and optionally you can put the ISCN formula, and the comments regarding prognosis depend on the centers or countries. Not in all centers this information is depicted, because it depends on the medical doctor's options. Okay, so, but we questioned, are there other cytogenetic prognostic and predictive biomarkers? We know from many years ago, more than 30 years ago, that the number of chromosomal aberrations impact on prognosis. You can see here a graph from this Juliusson et al. Paper from the 90s. And you can see here that patients having 3 or more abnormalities in this example had the poorest overall survival. So what do we do with genomic complexity? Is it important or not? I'm going to comment now on the technologies that we use to detect genomic complexity, that are chromosome binding analysis, genomic microarrays, and maybe in the future optical genome mapping, and the clinical impact of this biomarker. Regarding technologies, you know that the classical complex of the classical concept of complex karyotype is defined by having 3 or more cytogenetic abnormalities in the same cell clone detected by chromosome binding analysis. You can see here a complex karyotype from a CLL patient. Of course, the gold standard technology to detect complexity is chromosome binding analysis, and it's important to know that we need to use the correct mitogens to let the tumoral B lymphocytes divide and obtain metaphases. Because all the difficulties that we have experienced in the last years, within the ERIC group, the European Research Initiative on CLL, wanted to review and to offer a guideline paper that was published this year in Hemisphere, in which we covered all these issues. And I want to stress here this table 2 with technical recommendations for chromosome binding analysis, in which we tried to collect all this information regarding techniques and some tricks, and also the analysis. And I want to stress here that it's very important to use novel mitogens that were described. These are not so novel now, because these were described in the year 2006, 2007, but not implemented in routine until later. Okay, so what happens with the genomic microarrays? Genomic arrays are other technique. It's another technique that allows us also to see the genomic complexity. And we also performed a study that was published this year in Hematologica, in which we collected several patients from different countries in Europe, and we compared in the same patients the abnormalities detected by cytogenetics and bioarrays. The results showed us that these techniques are both useful, but are not equivalent methods to detect genomic complexity. You can see here that the concordant results that patients were stratified in the same groups were accounted for 70% of cases, but only 2.9% of patients were classified in opposite groups. I mean that if one case by chromosome binding analysis was classified as having high complexity, so 5 or more abnormalities, it was not detected by genomic arrays, or the contrary situation. You can see here the results, and with these all 2 techniques, we could stratify correctly the 3 groups regarding non-complexity or low complexity, intermediate and high complexity. And with the multivariate analysis, including all this data, you can see that hazard ratio was somehow higher using chromosome binding analysis than genomic microarrays. Regarding the clinical impact of genomic complexity, in the chemoimmunotherapy era, so these are retrospective studies, within the ERIC group published 2 important papers, one in 2019 and the other in 2021. And we collected many cases, in this case more than 5,000 cases and 1,000 cases, and we could demonstrate the following items. And we could say that the genomic complexity is an important factor, prognostic factor, in patients treated with immunochemotherapy, but not all the complex karyotype cases are equivalent. So cases having the multiple trisomies group, that means that they have trisomies 12, 19, and other trisomy or other structural abnormalities have a very good prognosis, are a special group. You can see here this graph from the overall survival, and this red curve are the patients that have these special complex karyotypes. So these patients perform very well. Cases that have 3 or 4 abnormalities, so we categorize them as low or intermediate complexity. These cases only impact on outcome if they have also TP53 deletions or mutations. And in contrast, these patients having 5 or more cytogenetic abnormalities, so were classified as having high complexity, were associated with the worst clinical outcome independently if the P53 abnormalities and absence of IGHV mutational status was present. But what happens now with the new agents? Because you know that in many countries, chemoimmunotherapy is not the elective therapy anymore, the first-line therapy. And you can see here from the review that the clinical impact, the results are controversial. Some studies say that complex karyotype does not impact on outcome, but others say that complex karyotype aggravates the outcome. So, in conclusion, the value, the prognostic and predictive value of complex karyotype is still a matter of debate. It depends on the complex karyotype or genomic complexity definition. You know that if we have these multiple trisomies, patients are going to have a very good prognosis, but if patients, for example, have 5 abnormalities or more, or associated with TP53 aberrations or absence of IGHV mutations, these patients are going to perform poorer. It depends on the type of patient, if the patient is fit versus unfit, frontline versus refractory, or for example, having Richter syndrome. And also regarding the type of treatment, you know that chemoimmunotherapy is the definition is clear, but not so clear with new agents. So this is the table, a figure of the paper on Hemisphere, and you can see here that some items are still unknown. So the conclusions of our paper were that chromosome banding analysis is standardized and feasible for CLL, and we stress to use the novel mitogens for CLL in cytogenetics, that chromosomal microarrays are also standardized, but no robust data are present on its clinical utility, and this technology is not used currently in the clinical trials. So if this technique is, we want to use it, we need some confirmation of its utility to detect complexity, or not to detect, but about the clinical impact. And cytogenetic analysis is not yet mature enough to guide the treatment choices in CLL. But Eric encourages the wide application of chromosome banding analysis, at least in clinical trials, to obtain these robust evidences of predictive value or specific cytogenetic profiles. And to conclude, I want to introduce these new tools for genomic complexity. Optical genome mapping, you know, that is a new technique that is spreading around the world. And it's a technique that allows us to analyze very long DNA molecules. And it's promising because it allows us to identify not only copy number changes as genomic microarrays, but also all the structural rearrangements that are present in this cell. So it's going to be probably in the future a new technique to detect genomic complexity. And with this last slide, I would like to thank you, and I finish my presentation. Thank you.
Thank you very much, Blanca. That was a very informative and educative overview of where we're at and where we might be going with cytogenetic analysis in the future. We can move now on to our second speaker, who is Dr. Panagiotis Baliakas. He graduated from the Faculty of Medicine in Thessaloniki in Greece. He then went on to obtain a PhD in the prognostication of CLL from the University of Uppsala in Sweden. He now works in the Department of Clinical Genetics at the Uppsala University Hospital, where he is a senior consultant specializing in hematology and clinical genetics, and he's also the medical director of the hematology laboratory. In addition, he also has his own research group at the Department of Immunology and Genetics and Pathology. I now pass you over to Panos, who's going to present us TP53 and immunoglobulin gene analysis.
Thank you very much for the invitation. I would also like to thank Dr. Espinet for this great presentation. I will proceed with talking about P53 mutations and IGHV mutational status in CLL. And first, I would like to clarify why we are having this presentation, because these two features, P53 mutation, IGHV status, are very pivotal regarding the choice of treatment. You can see here some algorithms regarding treatment in CLL, where patients are grouped depending on the presence of mutations or if they belong to mutated or unmutated CLL. And actually, what it is, the gold standard for patients with P53 mutation and unmutated CLL is the use of novel agents. This is almost standard in all European countries. And I would like first to start with the importance of the segregation of CLL in mutated and unmutated group. So B-cell receptor is actually a very important feature for all CLLs. It is the signature of the clone. It is stable throughout the course of the disease. And we know today that depending on the level of somatic hypermutation status, we have two very large groups. The ones that do not have that many mutations, and they called unmutated CLL, and the ones that have an identity below 98%, and they are called mutated CLL. Even though this threshold is arbitrary and does not reflect the actual biology of the disease, it is very important in the clinical setting. And that is why IGHV mutational status is probably the most significant prognostic feature in CLL. And these are data in more than 8,000 cases, where you can see how the curves separate from each other. Another important issue with this segregation in mutated and unmutated CLL is that the IGHV mutational status seems to impact and to influence the possible impact of different genomic aberrations. In other words, within each of these two groups of CLL, we have different genomic aberrations that seem to be clinically relevant. But even if we focus within one genomic aberration, the segregation in mutated and unmutated CLL seems to be relevant. For example, we can see here on your left, trisomy 12 CLL. This is considered to be an intermediate group when we talk prognostically. But actually, if we focus on mutated CLL, trisomy 12 seems to be associated with a dismal clinical outcome, whereas in unmutated CLL patients with trisomy 12 seem to do better. These are data based on the chemoimmunotherapy era. If we focus on point mutations, then we can see that depending on the mutation that we are investigating, we also have a different impact in terms of somatic hypermutation status. For example, in cases that are positive for NOTCH1 mutations, this NOTCH1 positivity seems to be highly relevant within mutated CLL, but it doesn't seem to play any role within unmutated CLL. Whereas for other abnormalities, such as mutations in SF3B1 or XPO1, you can see that this genomic background seems to be equally dismal in both mutated and unmutated CLL. If we focus on response to treatment and in the chemoimmunotherapy era, mutational status was also a very important predictive marker. So cases with unmutated CLL did not respond well, while those with mutated CLL, they could reach a very high level of MRD negativity, and almost 50% of these cases did not need any treatment even more than 10 years after the first cycle. This difference between mutated and unmutated CLL is no longer a problem with the novel agents, both BTK and BCL2 inhibitors, with both agents being equally relevant, equally successful in both mutated and unmutated CLL, not only frontline treatment, but also in refractory cases. However, As Dr. Espinet said in the beginning, CLL is very heterogeneous, and every time we try to specify a group, there are always some subgroups that do not follow the rules. So one could wonder, is this segregation in mutated and unmutated CLL unconditional? Do we have any exceptions? And one very important exception is stereotypy. As you know, almost 40% of CLL can be assigned in stereotype subsets. And what is a stereotype subset? It is a group of patients with CLL that are not related to each other. And these patients carry very similar B-cell receptors, as if they have the same clone. And we have a large number of stereotype subsets. And it is very interesting to see that these stereotype subsets have their own clinical biological profile, even though they all may belong to either mutated or unmutated CLL. For example, on your right, in the top of the screen, you have the cases that CLL subsets that all carry IGHV-434 gene. However, despite being all mutated, they do have different clinical outcomes. And the same stands for cases within unmutated CLL that carry IGHV-169 gene. It is also important to say that the segregation with mutated and unmutated CLL does not apply in those stereotype subsets that consist of both mutated and unmutated cases. The largest subset is subset 2. It is the one that carries the IGHV-321 gene. And we know that almost 50% of these cases belong to mutated CLL, and the rest of the cases belong to unmutated CLL. Within these subsets, the mutational load has no prognostic or predictive impact. And what is more important is that these cases that are highlighted by the green curve in your figure in your right, and when treated with chemoimmunotherapy, despite being mutated CLL, they have the same dismal prognosis with unmutated CLL. So IGHV is very important in the clinical setting, and I have to say that in order to be able to run this analysis, you can find help in the guidelines that are out there, and especially the guidelines that were about 1 year ago published by Eric can provide everything that you need. In that consensus document, they have separated the cases that undergo analysis for IGHV status, depending in if they were standard cases, meaning that they are cases that carry one productive sequence, or if they have more than one rearrangement. It is very important to be able to identify cases that have the borderline mutated status, meaning cases that have a load that is between 97 and 98%. And then it is also very important to be able to identify stereotype subsets, especially subset 2 and subset 8. Subset 2, since even when belonging to mutated CLL, has a very adverse clinical outcome, and subset 8 because it is associated with higher risk for Richter transformation. When it comes to challenging cases, it is very important to be able to identify cases that with more than one rearrangement, or cases that have a single unproductive rearrangement. In all these cases, the application of NGS can help us to really find what is the arrangement that represents the clone. And then sometimes when we have more than one productive rearrangements, it is also important to look back at our immunophenotype data at diagnosis, at the time of diagnosis, because sometimes we have patients that actually have more than one disease. Focusing now to the classical mutations, we can see that the molecular landscape in CLL is quite heterogeneous. And, as Dr. Espinet already mentioned, we have no CLL-specific genetic aberration. The same stands for the mutational profile of CLL. We have a great number of genes that are recurrently mutated in CLL. It's more than 2,000 actually that have been reported. And among these mutations, there are many candidate genes that may have a prognostic and predictive value. The most important one is TP53 gene. As already mentioned, mutations and deletion are considered equal when it comes to the prognostic and the predictive value. The great majority of cases carry both mutations and deletions, meaning the one allele is mutated and the other one is deleted. Cases that carry isolated mutations, and we also have cases that carry isolated deletions. The number of cases carrying isolated deletion is quite low, especially if we apply NGS for the detection of P53 mutations. Even though we all analyze and sequence P53 in CLL and in many other hematological malignancies, there are still many issues that need to be addressed. We have not yet reached consensus when it comes to interpretation of P53 variants, meaning what kind of algorithm do we follow when we want to interpret the variant, especially when this variant is a somatic one. We are not in agreement in what is the optimal threshold when reporting P53 variants that are detected with help of next generation sequencing. And then we also need to think, what does this P53 variant really represent when we analyze a patient with CLL, especially in the cases that we have not sorted the cells before the analysis. So when it comes to classification of somatic P53 variants, I just want to underline that we also need to take into consideration some synonymous mutations that are equally pathogenic as classical missense mutations because they seem to have an impact on splicing. And maybe we need to adjust our tools that we use so that we won't miss these variants at the time of filtering our data. There are not that much data out there regarding larger deletions of P53. They have been reported, but maybe our tools are not able to detect larger deletions in this gene, as well as in other genes. And then I also want to underline the fact that many P53 variants that were considered pathogenic for some many years ago, today are actually considered rare normal variants that have specific ethnic origin. And this is also something that we need to take into consideration. Another issue that is very interesting in CLL is that in CLL we have multiple mutations. So P53 is the most mutated gene in cancer, but in CLL we see that in about 10% of the cases, that may be even higher if we apply NGS technology, a great number of patients carry more than one mutations. And when we have this profile of multiple P53 mutations, then many of those are quite low, meaning lower than 10%. Whether the existence, the presence of multiple mutation as maybe an even worse clinical outcome, it is not well defined. But it is really interesting to be able to identify all these smaller clones and try to follow them prospectively. Which brings us in another question. What is the best, let's say, what is the optimal threshold regarding to P53 variants in CLL? What is the threshold that we should follow when we run our analysis and when we prepare our reports? So according to the EBI guidelines that were written some years ago, and now I know that there is work in progress about updating these guidelines, the threshold for the clinical report was 10% variant allele frequency. However, they also mentioned in this consensus paper that variants 5 to 10% can also be reported. Whether they should be taken into consideration for a clinical decision is another issue. And this is actually based in data from the chemoimmunotherapy era, where we know that smaller P53 clones were actually selected by the administration of chemoimmunotherapy, and they were the ones that drove relapse some months or years after the administration of treatment. But when we talk about variant allele frequency, what does it show? So we know that when we have a variant allele frequency of, let's say, 10%, and there are no deletions in the population that we are actually investigating, that corresponds to 20% of the cells. So by setting a threshold of 10% in the NGS data means that we actually are after a population that corresponds to 20% of the cells that we're analyzing. This is in contrast to what we consider as positive in the FISH context. So in the FISH context, the majority of the labs have like a 5% threshold, or its lab can set its own threshold based on the background of the specific analysis. So there is a quite high discordance between what we accept as a deletion regarding the number of cells and what we accept as a mutation regarding the numbers of cells, even though we, in the clinical setting, consider equal a deletion and a mutation. In order to address this issue, we try to see what happens with these variants that are below, that are between 5 and 15%. We know that when we run an NGS analysis and we have a variant with 9.5%, for example, if we rerun even the same sample, this variant may reach up to more than 10%. So we investigated with NGS, two NGS panels, patients with variants that were between 5 and 15%, and we saw that there was a really good concordance. Among the cases that we had these kind of variants, only one of them had also a deletion of 17p, meaning that the great majority of cases would have been considered as P53 wild type if one had followed the 10% threshold. However, that doesn't mean that everything that we see with our NGS panel is actually a real variant. And that is why we, again, went through all the samples and we tried to look more closely among cases that had a variant between 1 and 5%, and we tried to validate some of these variants using digital droplet PCR. The bottom line is that some of those mutations were rare, but some of the mutations were not. So one should be very careful when he's trying to report variants that are very close to the limit of detection for the specific method. And sometimes you may need to validate this with another technology or rerun the analysis in another sample. The last question that I would like to discuss with you is what does exactly a low P53 clone represent in a patient with CLL? If we sort our cells before the analysis, then probably what we see belongs to the clone. But if we don't do that and we just analyze blood, then there is a possibility that the little clone that we actually detect is not in the CLL cells, but it could be what is called clonal hematopoiesis. So clonal hematopoiesis is a normal phenomenon, mostly among the elderly, and it is like mutations in genes that have been reported as recurrently mutated in myeloid malignancy in healthy individuals. And among the genes that are recurrently mutated in the CHIP context, apart here DNMT3A and S6LN1 and TET2, we also see P53. The presence of these clones is associated with the risk for a myeloid malignancy in the future, and it is also associated with higher death rates for cardiovascular diseases. What we try to do is we try to investigate the presence of CHIP in CLL, and that was done taking into consideration the median older of patients with CLL, that is, as Dr. Espinet said before, above 70 years. So according to these results, CHIP was present in 10% of patients. And what is interesting is that the prevalence of CHIP seems not to be influenced by the age. The genes that were actually mutated are the usual ones. We had a little arrangement for mutations in the RAS pathway. But what was also more important is that these mutations that were detected at the CLL diagnosis and probably represent a CHIP clone were the ones that after some years, after the administration of chemotherapy, the ones that actually drove the emergence of myeloid malignancy. So the ones that, the clones of CHIP that we see in CLL patients may be clinically relevant, and the presence of the TP53 could dictate treatment even if it does not belong to the CLL clone. In order to sum up this part of the presentation, I would like to say that P53 and IGHV status are, as you all know, of great prognostic and predictive value in CLL, and that is why both of them should be assessed before the administration of treatment, not only upfront, but also in time of relapse. This is mostly for P53. For IGHV status should be actually evaluated only once. When we do analysis for these biomarkers, we need to follow the guidelines as long as they are available and updated. We need to be very careful. We need to validate our results, especially if we want to lower the thresholds of our reported variants. And sometimes we actually need to think out of the box, especially when we have patients with borderline findings. With that, I would like to thank you for your attention, and I hope that we have questions to answer to.
Thank you very much, Panos. A reminder, we have a questions box facility on the dashboard of the presentation. If anybody has any questions that they would like to ask presenters, then please feel free.
Can I just perhaps ask a question to
Blanca?
Do you think that going forward it's going to be better to determine genomic complexity by chromosome banding, or do you think that eventually it would be substituted by array analysis or eventually OGM?
Thank you for the question. In fact, I think that now the technique, the gold standard is cytogenetic, is chromosome banding analysis, and it gives us a lot of information regarding structural and copy number, and it is the only technique that has been used in several clinical trials, and we have robust results until now. I think that is easier to use it because it is implemented in many laboratories, not for CLL, but for any other type of hematological malignancies, and that the protocol is not difficult. And this is not the case for genomic arrays that are not available in all the centers for routine diagnosis. Only in some European countries they use this technique, but not others. So I think that for complexity, at least until now, I think that chromosome banding analysis is the best way. But I don't know what's going to happen in the future, because optical genome mapping is a very nice technique, but of course it needs to be validated. It needs to be first implemented in the labs, not only for research, but also for diagnosis. I think that this technique has a future for some applications in the labs, because it is in between these old techniques or classical techniques and the whole genome sequencing, which is not ready to use in the labs to see all the structural aberrations that are present in these cells. And I think that this methodology is gonna be useful in hematology in many cases, but I don't think it's ready now to be implemented, because we still need guidelines, we still need the cutoff. We don't know exactly which is the cutoff to consider that a case is complex. We need to study for sure more and more cases, but there is a potential there.
Okay, thank you very much.
Can I ask something to Panagiotis?
Of course.
Okay, I just wanted to know if you have implemented 100% NGS technology to detect IGHV and P53 mutations in your lab?
If we have detected, I cannot hear you.
No, if you have implemented, or you're still using Sanger sequencing in certain cases or not?
It is only NGS for P53 mutation, and this for about 10 years ago.
Mm-hmm. And for IGHV mutation?
For IGHV, it is classical Sanger.
So when you're detecting very low level VAFs of P53 and you're suggesting that it could in some cases be associated with another pathology that's actually in the patient, we know that quite a lot often we have this. Do you try cell selection to look at the?
I can say what we do in our lab. We have our threshold of 3 to 5%, and our method is validated for this threshold. And when we see lower VAF P53, then we are currently running a research project where we include these cases in a prospective follow-up, and it depends also in the diagnosis, because the same problem with the VAF threshold is not only for CLL, it is the same for all malignancies in hematology where you will set the threshold. So what we are trying to do is we try to follow them prospectively to see how this clone will evolve. Sometimes when we have like a borderline finding, and depending also in the purity of the sample, because we don't do a sorting, we can, in collaboration with the clinicians, take a new sample or in a few months, or it depends. It is quite individualized when we have these kind of clones, the small clone.
Thank you.
Yeah, I also want to comment on this because there is a paper from the Bernal group analyzing these small clones on TP53, and they said that the impact was very clear that these clones were going to grow with chemoimmunotherapy treatments, but the prognosis of these small TP53 clones is not so clear with the new drugs. So it's something that what I think is that all our guidelines, the guidelines that we are using until now were like mainly based on chemoimmunotherapy findings, and now things are like moving. It's true that the follow-up of these patients that have started with the new drugs is short. I mean, it's only like 5 to 10 years, and it's not like, maybe in some cases the clone has not, I mean, the patient has not been followed a lot to be able to see how these patients progress or not. But, well, it's something that I always keep saying, that maybe we need to revisit these guidelines and to see if these biomarkers are going to be the same or not. For example, for FISH, I always say that I don't think it's useful to test for 13q and chromosome trisomy 12. Maybe we could avoid this and focus in other aberrations on other biomarkers, and well, just something to discuss. What do you think?
Yeah, if you're asking me, I think I completely agree. It is also an issue whether these new agents are like administered in patients that are refractory, or if they are administered in front line. It's not the same disease when it's like front line, or when it is like after being treated with other treatments. I agree with you that in the future is going to be some other kind of diagnostic approach. I do believe that we don't need to have the same approach for all patients. I mean, we talk about precision medicine in the context of treatment, that maybe we should also start talking about precision medicine in the context of diagnostics. Whereas it's not all patients that need to be so comprehensively investigated. So maybe we need to have different pipelines. We can have, for example, a very good NGS approach with a very good CNV backbone, where you probably could also detect some standard copy number variations that are prognostically important, and have this parallel possibility with, as you named, optimal sequencing, or some other way of high throughput, in order to better characterize the patients when we really have an indication for that. So this one size fits all may not be the best way to follow, even in diagnostics. We probably need to have different diagnostic approaches.
Yeah. I've got a question here in the question box, probably aimed at yourself, Panos, that says, what do you think about changing IGH status in a CLL patient? Could it be treatment related, or rather a technical issue related to method sensitivity?
Well, there have been reports of this, of the patients changing. I don't know if it could be like present from the beginning. It could be a biclonal that was not detected in the beginning. I think in all these cases, NGS could help us to really understand what has been happening. And then we also need to take into consideration that sometimes CLL coexists with other mature B-cell malignancies, and then we should know what does this clone really represent.
Thank you. I think we've just got another one coming as well. So we've got a thank you to both presenters for a very helpful presentation. I wonder if Panagiotis would be able to elaborate on how he interprets TP53 variants. Specifically, does he follow the ERIC guidelines or use other guidance as well?
For the interpretation,
yeah.
Well, we actually have developed an in-house algorithm approach in order to be able to interpret the variants that we have, and this is something that we apply in all kind of variants. So not only in CLL, but also in myeloid malignancies or any other analysis that we do. This is mostly based on the guidelines of the Belgian group that were published about 2-3 years ago, and they are very helpful in order to be able to interpret the somatic variant. But we have also some extra features that we take into consideration. So we use our own interpretation algorithm for that. But the gold standard by also following the ERIC algorithm is very helpful.
I think just that there's a good point to close. We're bang on 2 o'clock. So thank you again, Panos and Blanca, for your presentations today, and thank you for those who sent in the questions. If you all keep your eyes peeled, we should be advertising very shortly our next Focus On session for November. So until then, thank you very much for everybody in attending. Bye.
Thank you for being here.
Bye. Thank you. Bye.